Hey guys, welcome to part 2 of acute psychosis. Okay, so we said that a patient can come in with acute psychosis, and we've mentioned the symptoms that a patient must have in order for us to say they've got psychosis. So we said that a patient must have one of these 4 symptoms. They don't have to have all of them. So they can have delusions, they can have hallucinations, they can have disorganized speech, disorganized behavior, including catatonia. So those are symptoms of psychosis. So if a patient has got another psychiatric illness and they've got one of these symptoms, it means that they've got that psychiatric illness plus psychotic features. The fact that they've got this, like for instance, I said, you can have a patient who's got MDD, but now they've got delusions, or now they've got disorganized behavior. Then it means they've got MDD with psychotic features. Or you can have someone who's got bipolar, but now they exhibit one of the signs of psychosis, symptoms of psychosis. Then that's MDD with psychotic features, or bipolar with psychotic features. So yeah. So that patient comes in, has got acute psychosis. When they come in, you don't know whether they've got a primary psychotic disorder when they come in, which we spoke about, schizophrenia and the spectrum. You don't know whether they've got an underlying psychiatric illness, whether they've got an anxiety, whether they've got a personality disorder, or whether they've got any psychiatric illness. You don't know whether they've got any psychiatric illness. You don't know whether they've got any psychotic, and we know what psychotic disorders are. It's schizophrenia and the spectrum, which is schizophrenia from brief psychotic disorder, and schizoaffective. So those are your psychotic disorders. You don't know whether this patient has got psychosis secondary to a substance. You don't know whether this patient has got psychosis secondary to some kind of medication or even some kind of poison. You don't know whether this patient has got psychosis secondary to another medical condition. So you don't know when they come. This is one thing that I didn't understand. You see, a patient comes in, they are known to have let's say they are known to have MDD. Let's say this patient is known to have a major depressive disorder. Now, when they come in presenting with symptoms of MDD, now you are asked to work this patient up. I used to be like, in my mind, but we already know that this patient has got MDD. Why are we working this patient up? Why are we doing bloods again and all these things? But the truth is this: you can have someone who's got an underlying. Let me put it this way. Let me say this. I've got a 33. I want you to understand this. I've got a 33-year-old male patient known with major depressive disorder, for instance, has been on this treatment for 2 years, for instance, has been on treatment for 2 years. Now they come in with depressive symptoms. And when they come in with depressive symptoms, I'm like, okay, let me call the psychiatrist to see the patient. And they'll be like, no, do the bloods first. Why are we doing bloods on this patient? The issue is this. This patient, the fact that they've got MDD does not mean that they will never have another medical condition that can make them to be depressed again. Doesn't mean that just because their MDD was not attributed to a substance, doesn't mean that they will never take substance. I hope you get that. So it's still worthwhile to still do the urine toxicology, do the bloods again. Not unless, I mean, but the urine becomes very, very important, because when you are depressed, for instance, you can be on an antidepressant for 2 years, you are doing well on it. But then something happened, you ended up using some drugs. You started taking cannabis. Now, that cannabis makes you depressed, for instance. So now it means that you have got a primary psychiatric illness, you've got MDD, right? It's fine. But now the cannabis could also be contributing to, and we want to know that if you've got a substance use disorder as well, or you've got substance-induced depressive symptoms. So we want to know that as well. So that's the reason. Some people would say, if the bloods were done before, don't worry about the bloods, but at least do the urine. So it just depends. But I just want to explain that part. Okay, so now that patient comes in, you do your history, right? You do your physical examination. I'm not going to talk about the history there. Obviously, the symptoms. And also, in psychiatric patients, especially if they're psychotic, collateral becomes important. Collateral history becomes very important. Becomes very important, meaning history from the spouse, the relatives, the kids, all that. Especially, yeah, obviously, kids that can speak, that are older, that can speak, and all that. And then, so from the history, you will pick up your symptoms that they've got psychotic features, and then you go on with your other history, past medical history, substance use history, past psychiatric history, forensic history, personal history, and all of that. And then you come to physical examination. Physical examination is important to rule out a medical condition, features of a medical. For instance, patient comes in with psychosis, but they are pale. Patient comes in with psychosis, but they've got tremors. Patients come in with psychosis, but they are malnourished. Patient comes in with psychosis, but they've got... So a patient who's got psychosis, they are not immune from getting other medical conditions. So it becomes very important. And also, you can see if the patient has got any signs of injuries, that they might have injured themselves, they might also have been injured by other people. So this is a casualty setup. In psychiatry, they don't really do physical examination, not unless the patient complains. But when the patient comes in, these patients will come into casualty, into your practice, into the clinic. So the physical examination will be important there, a full physical examination. And then after that, you do the MSE. There is no psychiatric patient that should not have an MSE. An MSE is golden to psychiatrists. So you do your MSE. After doing your MSE, and then obviously you make your investigations. That's what I want us to talk about now. What are the relevant investigations that you are going to take? And later on, we are going to talk about, maybe we should do it now. Okay, so on your investigations, the reason why we do investigations is because you want to rule out a substance problem. You want to rule out a medical condition, so that you can now label your patient as having a primary psychiatric condition, not a condition that is secondary to any of these. I hope you get that. So that's the reason. So you cannot say someone has got like, for instance, this patient is psychotic. You want to know, Ugoti, this psychosis, is it due to a substance, or is it due to medication, or is it due to another medical condition? Before you can say, no, I think their psychosis is just a primary psychiatric psychosis. It's secondary to, it's primary. So there's no cause, there's no identifiable cause for it. Because if you jump, before doing this, you jump and say the patient has got primary psychosis in this case, it means that they will continue using the substance, and they will never get better because you didn't pick up they are using a substance, and then because you need to deal with the substance as well. They need to go for sessions, counseling, rehab if needs be. Or they've got a medical condition. That medical condition, as long as it's not addressed, they will keep being psychotic. So that's why it's very, very important to rule out a secondary cause. Imagine a scenario whereby I see a psychotic patient and I just label them as having whatever psychotic disorder, and I take them to the ward. I start them on treatment. They don't get better in the ward, and then they actually die. Simply because the precipitating medical condition was never addressed. Be it syphilis, be it some kind of electrolyte imbalance, be it some kind of an inflammatory process, so things like that, be it even dehydration, you see, especially with the elderly. So that's where the thing is. So by the time you refer them to a psychiatrist, you want to have at least ruled out all of these. Because if you find that they are psychotic but they've got some precipitating medical condition, you need to treat that, because it could be that after treating the medical condition, the patient will become fine again, and then they're not labeled as having a primary psychotic problem. For instance, if you've got psychotic features because of electrolyte imbalances, once you correct the electrolytes, the patient should become fine. If they've got an infection in their brain, they should become fine once that settles. So you don't have to involve the psychiatrist now. Disaster can happen if the psychiatrist accepts your patient that has got an underlying medical condition. They accept them in their ward, and then when they get there, no one actually gives them the medication that they're supposed to be getting. They're busy entertaining the psychosis, and the patient dies in the ward. It can be very disastrous. So that's why the psychiatrists are very strict with the results. It's not because they're being funny or anything like that. It's because they want to make sure that everyone is safe. They are protecting you, the discussing doctor, and them, the accepting, and also even the patient, most importantly the patient. So yeah, so the conditions that there's no way I'm going to mention all of them, but the conditions that can, medical conditions, like I've mentioned, substances, that the common ones. So the substances you use, so the investigations for substances, do a urine toxicology. You just write urine toxicology on the form, and then the lab is going to run almost all the ones that they have, like the reagents that they have, they'll run the test. So usually there's lots of them, but you're just looking for the positive ones. So they'll check for benzodiazepines. If they're there, they will tell you. They'll check for cannabis. There are many of them. Cannabis, methamphetamine, methadone. There are so many, guys. There are so many of them. Cannabis is the most common one here. And then, so that's your so you take the urine, sent to the lab. And then when it comes to medical conditions, things like hepatic encephalopathy. So you want to know how the liver is. So the way of checking how the liver is by doing the LFTs. You want to check if they've got some infection. The only way to screen for infection is do a FBC, CRP. If they've got an inflammatory process, whatever inflammation, and a systemic inflammatory condition, your ESR should pick that up. If they've got some kind of, let's say, neurosyphilis, neurosyphilis can give you psychosis, so you do RPR there, RPR. If they've got some electrolyte imbalances, your UNEs should help you there. You know, UNEs tell you about electrolytes, and also they tell you about the level of hydration as well. Like, one of the things that go up with dehydration is your creatinine and your urea. So if they've got some kind of electrolyte imbalance, so if guys, they ask you, how do you wake up a patient who's got acute psychosis, these are the things that you will mention. These bloods, LFT, FBC, CRP, ESR, RPR. You know where we are. I know in Gauteng, the issue of NCC, neurocystic psychosis, is not that prevalent. They don't even think about it when they're investigating patients. But in the Eastern Cape, you cannot not do an NCC. It's very common. It's a very common cause of epilepsy. So it's basically a neurological condition. So any neurological condition can give you psychosis. Majority of them can give you psychosis. So you can also have some endocrine problems, especially hyperthyroidism. There you can do your TSH. There's a debate between doing T4 or TSH. Some people, what I was taught is that when you want to screen for a thyroid problem, just do the TSH only and not do the T3 or T4, just with the TSH. Then based on the TSH, you can now see what do I need to do the T4 now. But some people say do both, but for me it makes sense that I just do the TSH. Because if your TSH, if you know how to interpret TSH, then you'll know if it's high, how should the T4 be, or if the TSH is low, how should the T4 be. What else is so, and then you can also have things like your deficiencies, like B12, folate. So you do that as well. So you do B12, vitamin B12, and you do your folate. You do your folate. So what you so these are like your basic bloods, ne? These are your basic bloods. These are your basic bloods, except NCC. The NCC is basic for us. We're in the Eastern Cape, but it's not basic in other places, but the others are basic. So the other investigations will depend on the clinical presentation. So if now you've got someone who's psychotic, but they've got some focal signs, then it means now you must consider imaging, brain imaging, like your CT or your MRI, if they've got focal signs and all of that. They've got some weakness, they've got some paralysis or paresis, they've got some cranial nerve fallout, things like that. Then you might consider, because you might be dealing with a mess or some kind of a bleed or whatever the case might be. So basically, guys, I'm gonna leave it here for this part. So at least this is very important, guys. It's very important Maybe some other time I will talk about history taking in psychiatry. But the point that I wanted to drive here is that how should your thinking be when you see someone who's got acute psychosis? Your thinking should be, am I dealing with a primary psychotic disorder or am I dealing with a secondary? That's number one. Number two, am I dealing with, okay, let me start again. You've got acute psychosis. The thing is, you want to know, am I dealing with someone who's got aggression or they're not aggressive? Because when they are aggressive, you need to take care of the aggression first. Later on, then you worry about, am I dealing with a primary psychotic disorder, like I mentioned, schizophrenia and the spectrums? Or am I dealing with just a psychiatric illness, a primary psychiatric illness with psychotic features? That's your thinking. Or am I dealing with a secondary cause, like a substance, medication, or another medical condition? Ne? Then from there on, okay, it's fine. Do your history, the way you were taught, do your physical examination, do your MSE, then your investigations. You've got urine and then you've got blood. This is blood. The urine, you don't have to specify what you want. Just do. They will do a urine screen, a urine screen, toxicology. They will look for everything in that urine. Then they will tell you what is positive, what is negative. And then your bloods are these. And your bloods are in line with this. Because you are thinking, am I dealing with infection? A psychiatrist will not accept a patient who's psychotic, who's got a high white cell count, or who's got a high CRP, who's got a high ESR. They want this to be normal before they can take the patient. Which means if anything is abnormal here, you must correct that first. That's why they talk about 72 hours. 72-hour observation. In that 72-hour observation, you do the bloods on the first 24 hours, do the management, the acute management, and then wait for the bloods. Obviously, you are going to give them something to sedate them. You might even start them on antipsychotics. And then while you are waking them up, once all of these are normal, then you start calling the psychiatrist now. That's why psychiatrists, they never actually wake up at night to go and see a patient. It's because the casualty officer will do all these things. So we cannot escape it, guys. Okay, so the next time we are going to talk about what are the drugs that you give now. That's going to be our part 3. Guys, I love you so much. Thank you for your support.